Hello, and welcome to the Lupus Forum review of the 2021 ACR Convergence. So one of the things we're going to be doing at the Lupus Forum is reviewing the conferences to keep you up to date on the highlights of the latest data. And I'm joined for this by two of the other members of our steering committee, with Chris Edwards from University of Southampton in the United Kingdom, and Vibeke Strand from Stanford University School of Medicine in California for this review. Welcome, Chris and Vibeke.
Hi, Ed.
Hi there.
So, Vibeke, could I turn to you first? What were your highlights of the conference of this year? Could you introduce us to the first of the abstracts that we selected?
Sure, but I'm just going to say one thing about the conference. I think they did a terrific job of organizing a totally virtual conference that was supposed to be in San Francisco and then was scheduled on European time, which was quite early. I was up at 4:30 to present an oral abstract, which seemed a little much, but that's all right. One of the things was the community hubs. And for the lupus community hub, there were as many as 200 people at any given time in one of the meetings. And I think another highlight was the debate about belimumab versus voclosporin in lupus nephritis. So just a couple of points.
Yeah, I agree.
Lots of good data. So this is from the Toronto group, and it's the Ular ACR 2019 classification criteria. And what they've done is, instead of using it as that, to use it for a measure of disease activity and damage. So they decided that they'd shown if you had a score of 20 or greater, that this would predict long-term outcomes. And this is from part of their cohort, which only had about 2 or 3 months of disease when they were entered. And they've been followed for a full 10 years. So there's quite a bit of data. And essentially what they did show is if you had a score of 20 sometime or other within those 10 years, you had significantly more renal damage, you had a higher incidence of diabetes, but you had twice the probability of dying.
Yeah, so I noticed this one too. And I mean, my thought, I mean, the suggestion seems to be here that maybe when we see new lupus patients, we should calculate the ACR classification criteria score and then maybe give more aggressive treatment if their score is over 20. Do you think that's something you would do based on these data?
Well, I found these classification criteria to be very useful in terms of understanding what you should do to treat lupus and what was available. And they, of course, had done a very thorough review of all of the literature, et cetera. But I think a score of 20, this is not meant to be a disease or damage score. And if you have a score of 20 with these criteria, almost always you're going to have lupus nephritis and several other severe manifestations. And we already know that the SDI tells us that information.
Yeah, that was exactly my thoughts. Yeah.
Yeah, it was the cut of the level, wasn't it? It's by taking it so high, because already with classification criteria for lupus, I've always, I think lots of us do, looked at broadly how many are there, how many of the classification criteria are present, and have divided people therefore up into people I'd predict to do worse or better. But it's when you set it so high, that's not necessarily the thing you do in the real world, I think.
It feels like if a patient's got to that score, the problem's already happened.
Yeah.
Yes.
I appreciated what the need, which is that when I diagnose a new lupus patient, sometimes I think they look quite mild, but I start looking at their blood tests and I start thinking we might be heading for trouble here. Mm-hmm. And I think we do need that, but I'm not sure that just looking at clinical features is that.
Well, remember, this is a span of 10 years. So it's when and if you develop that score anytime in those 10 years.
Yeah. Okay, so shall we go on to, I think we next, Chris, you've chosen a few of the abstracts based around baricitinib.
Okay, so for those of us who have an interest, as many of us do, in treating patients with inflammatory arthritis as well as seeing patients with lupus, it's always interesting to see old friends being used. And here's baricitinib, of course, a JAK inhibitor. And this is a post hoc analysis of a study that's already been published. So we've seen work on baricitinib in lupus published, the big phase 2 paper was, I think, 2018. And Thomas Dorner presented this work. And what they were trying to look at the individuals who were seropositive, who had anti-double-stranded DNA antibodies, and look to see what happened to the levels of the anti-double-stranded DNA antibodies and the IgG levels, so total IgG levels over time, and relate that to disease activity with one of the disease activity metrics as well. And they looked at that for the different doses that we used, the 4 milligrams and the 2 milligrams. And what they could see is that were changes in serologic biomarkers, not all of them, but anti-double-stranded DNA came down. The overall IgG level came down. Some other things didn't. But I think the point of this was trying to demonstrate that here's a drug that we're used to thinking about in terms of its effect on inflammatory cytokines. And here it is having effects on serology and therefore presumably B cells as well. So, we could discuss that. I don't know if Vibeke or Ed, you have any thoughts about this?
I mean, yeah, my thought, one thing that's interesting is a lot of that is quite similar to what we saw when we first started using B-cell targeted therapies, isn't it? Like using Rituximab, that I remember these publications that came out when it first started to be used saying, well, look, double-stranded DNA is quite dynamic and that comes down, but other antibodies like Rho and Ular antibodies don't seem to change much with Rituximab. And it's funny, isn't it, to see the same story with a drug that targets something completely different.
So I've actually looked across a lot of lupus trials, failed and successful. And almost always those patients who have dsDNA antibodies and low C3 and or C4 are the ones more likely to respond, regardless of the mechanism. So I think there's something about the disease activity as well that we see with this.
Yeah. And is that because it's selecting out the people who have definite lupus that has modifiable aspects to the immunology? Is that what we're seeing, rather than the people with lupus who have lots of pain and other problems? Do you think it's about that, about getting the right population?
I think it might be part of it. If you're thinking about the type 1 versus type 2 that the folks at Duke have been trying to describe, but it has been a good way to select patients who are more likely to respond in clinical trials. So I think it's more the disease.
Yeah, the type of disease. Okay, so I'm going to move on then. So there's another baricitinib. So it's from the same study, but this is looking at a different aspect. So Thomas Dorner once again, and it's another post-hoc analysis of the same phase 2 study. And this is now looking at different inflammatory cytokines. And there's some other interesting things that come up. So here are some chemokines, of course, chemoattractant cytokines, and they looked at relationships to a number of these after treatment, and they could see that there were some changes, downregulation in some of these cytokines, which you can see here. The other thing that I picked out that was interesting, and this sort of overlaps once again into inflammatory arthritis as well, because there are also effects on bone markers, so rank ligand and artemin. I hadn't come across artemin before, but there's a bit of work around it. Maybe you're both more familiar with this, around pain and bone pain in relation to other diseases like osteoarthritis. And it starts to make you think, oh, isn't that interesting, this story about JAK inhibitors and pain, and whether there's some effect through this effect on artemin. But, so we've looked at an effect on serology, and here we're looking at a selection of different inflammatory cytokines, particularly chemokines.
Yeah, I mean, exactly that. I mean, that's very interesting when you think to the phase 2 study of baricitinib, where you go down from the headline response rate to some of the organ-specific measures. Mm-hmm. And when you look at the arthritis measures, I always think immunosuppressants will have the most consistent and reliable effect on joint swelling, because that's inflammation. And it might be a little bit less clear for tenderness, because that might not always be due to active inflammation. But actually in this study, it was tenderness and the pain scores that improved more, which is a fascinating observation. And, here's a potential biologic explanation for that.
Yeah. And the artemin story. I don't know if you'd come across that before.
Not really, although as you know, you and I have both studied lupus arthritis quite a bit, and there are some significant differences in the way it presents from rheumatoid, aren't there, where the sign of itis is often a bit less obvious. you wonder.
There's been a discussion. There's been a discussion actually at ACR about this business of the joint manifestations in lupus, and are they really swollen and tender joints, or are they more periarticular? And they're definitely painful, and we can definitely determine that there's inflammation. But that probably also links with this, because we do know that the arthritis of lupus is quite different.
Absolutely, yeah. So that's and the other thing I noticed on this abstract, well, the other thing that it made me think, I suppose, is that I think one of the motivations for using baricitinib in lupus was because we know that this will block interferon. And everyone is convinced that interferon's a good target in lupus. But when you see data like this with all, and I suppose that first line there, that the chemokines are correlating with the interferon signature, yeah, okay, that's what I'd expect. Interferon impacts on those chemokines. And so, but I mean, when you start to see all these other cytokines coming down, and you start to maybe see patterns of clinical benefits that maybe seem a little bit different to what you saw with anifrolumab, is that really how it works? It blocks many cytokines, and maybe the reason it's helpful is not because of its effects on interferon, it's because it blocks other inflammatory cytokines too.
Yeah, the complexity gets more and more, doesn't it? And you see these the tables that people use to map out the different families, the family tree of different diseases. And as you go through these things, you go, okay, that I was expecting, that I wasn't expecting. This different treatment works because of this particular mechanism. Yeah, and so yeah, we keep learning about what's truly driving the disease.
I think these are the recurring themes of all. It's going to be the recurring theme of all this discussion, isn't it? That you've got more and more mechanisms of action, more and more ways of working out who to treat what, and you start to see what managing lupus is going to look like in 5-10 years' time, where you've got a choice of 6-7 different molecular targets to choose from. Should we go?
Yes, and our patients already take 5 pills a day or twice a day, right? Yeah.
So I'll talk a bit to the anifrolumab data that was shown at ACR. So the main thing that we've seen at ACR, we've seen the original TULIP-1 and TULIP-2 studies and the recent license for anifrolumab in non-renal lupus. And just continuing the last point we were discussing, what AstraZeneca have been looking at now is polling the populations of those 2 studies and then trying to break down different patient groups to see where the treatment benefits seem to be greater or lesser. So there's a few of these, and the first one is about an outcome measure called the LLDAS, the Lupus Low Disease Activity State in response to anifrolumab. So this is an outcome measure that was developed. A lead in the development of this was Eric Morand at Monash University, who's also a member of our steering committee and the first author on this abstract. And so the LLDAS is an outcome measure that asks not just for a response, as in a reduction of disease activity from baseline, it's a state. So the patients have to have below a SLEDAI of 4, no involvement in major organs, and they have a prednisolone dose of 7.5 or less and stable other immunosuppressants. So it's a more rigorous endpoint that's more difficult to meet, and it also, you can't meet it just by increasing steroids. So here, and I think that's shown in the results here. So you see that the numbers of patients at week 52 who are in LLDAS is higher for anifrolumab than it is for placebo. But of course, this is something that you don't just, this is a measure that you don't just look at week 52. You look at it all the way across the study. So you can see that it increases as you go across the 52 weeks of the study. It's achieved earlier in anifrolumab. And what that means is the anifrolumab treated patients were more likely to have sustained periods in LLDAS rather than just meet it at the end. And that's something that's been shown to correlate with damage. Do we want to ask?
So we were doing BICLA responders. I mean, obviously they changed the primary endpoint. So then they came to BICLA responders for both of the trials. That's really the analysis that makes the most sense. So looking at LL DAS attainment and the BICLA responders is what I think makes the difference. But of course, you can see that there are some patients who do well because they're obviously on background therapy that's effective and active. And so we always have these questions with each of the trials. So what's interesting to me is that, remember, Bliss 52 and 76 had differences of 10 and 14% between the SRI4 responders and non-responders. Here, actually, in this study, it was a 16% difference. So really wasn't very different. This seems to be as good as we get with what are clearly effective therapies.
I mean, one thing I wonder about, which I think this method of analysis suggests, is the thing about an SRI4 or a BICLA study is it's all based on what you had on day one at baseline. So because when I've tried to recruit patients to these studies, one of the problems is getting somebody who has the right amount of disease activity with the right stable therapies and the right steroid dose on the day of screening to get them into one of these trials is difficult. Because their disease activity is up and down all the time and their steroid dose is up and down. It's hard. And so when you take these landmark endpoints at 52 weeks and just compare them back to that day, you're sort of ignoring a lot of stuff that happens in between, aren't you? That I just wonder whether this idea of looking at more at the how many months you're in low disease activity, sustained periods, may be quite, in some ways, more meaningful to patients.
Yeah.
Okay, and we'll go to the next one. So the next analysis on the pooled data, again, this is the pooled TULIP-1 and TULIP-2 randomized controlled trials, at least the placebo and the 300 milligram doses. And this one looked at prior biologic exposure. So although we don't have as many biologics for lupus as we have for rheumatoid arthritis, we have belimumab, and some patients will receive rituximab as well. And so in this study, they looked at these two groups, biologic experienced and biologic naive patients. And so the result was that anifrolumab's benefit compared to placebo was comparable or greater in the biologic experienced and the biologic naive patients. So the placebo responses weren't as good in the biologic experienced patients as you might predict, but the added benefit of anifrolumab appeared to be the same in those two groups, or even better in the biologic experienced. But offsetting that, the safety was worse in the biologic experienced patients, whether they were receiving placebo or anifrolumab, and that included herpes zoster, which is an AE of special interest.
So that greater response in the biologic experienced patient is sort of counterintuitive, isn't it, from what we know from other diseases? So do you think this is about selection of patients again, and it's a particular group that have been on it and who have worse disease or are more?
That's what I was thinking about. That going back to older RA literature, we always used to think biologic naive patients do the best. The more biologics you fail, the less and less good responses you get to more therapies. Is that because damage makes it harder to meet the response endpoints? Maybe. But one thing I thought about here is that if you think of the biologics they might have had, they're both B-cell biologics. And you might almost think that if you failed one of them, perhaps you're not likely to do very well on another biologic for the same class, perhaps. But now we're switching to a completely different class of therapy. And so maybe patients who've got active enough disease to have warranted trying a biologic, that's the wrong class of therapy for them. Maybe they have a really good chance when you switch to another class of therapy.
Yeah, or I guess they had to be completely washed out of the system for them to be included, didn't they? You know, you also wonder about sequencing and this idea of using biologics in a particular sequence having an effect.
Yeah.
So we do see lower placebo responses in biologic experienced RA patients, but in general, across the JAKs is what I'm thinking of.
Yeah,
you see very similar responses to active therapy between the DMARD IR and the biologic IR. So it's kind of interesting. It's a little different.
Yeah.
The next abstract were on this pooled cohort of TULIP-1 and TULIP-2 is looking not at previous therapy, but at the duration of disease. So this is one by Kalunian and colleagues. So here, so in lupus, of course, again, this may be something that differs a little bit from RA, but often all the severity and all the worst disease can sometimes be in the first couple of years. And so so here they've compared patients in those studies who had recent onset disease, which meant disease in the first 2 years, compared to those with established disease, disease lasting longer than 2 years. So when you look at those two groups at baseline, as you might expect, there are a few differences. So those with established disease were more likely to have a high interferon signature, to have positive double-stranded DNA antibodies, to have more severe disease activity, and to be on more therapy. But despite that difference, there seemed to be a similar treatment benefit of anifrolumab compared to placebo, based on the primary endpoint, the BICLA at week 52, regardless of which of those groups these patients were in. So again, suggesting this therapy is useful at both phases, whether it's early disease that seems quite aggressive, the kind of disease we were talking about at the start, or whether it's disease that's been there for quite a long time and quite a few other therapies have failed.
So something that we've done is analyze the BICLA responders versus non-responders by the patient-reported outcomes. And those data are really strong. Not just patient global or pain, but SF36, all the domains, and all the domains of lupus qual, and even facet fatigue. And they're all highly clinically meaningful as well as being statistically significant. But for some reason, AstraZeneca didn't want to add these abstracts to either ACR or Ular, but it's coming out in Lancet Rheumatology soon. So again, just another way of showing that there's benefit to the patients.
Yeah, I mean, it's very significant, isn't it? Because some of those endpoints are they can be more challenging to meet in some of the lupus trials, can't they? Where some clinical endpoints are met, but I don't think, not always, the health-related quality of life is there.
It's the usual difference between how the patient feels and what the doctor thinks.
Yeah. Okay, and the last of the anifrolumab abstracts on this pooled cohort was about serological subgroups. So again, relating back to some of the other things we've talked about in other abstracts, with anifrolumab, this is a drug that targets type 1 interferon, but the baseline serological markers, the double-stranded DNA and the complement, appear to be helpful in predicting response. So the anifrolumab response rates were generally higher in patients who had serological abnormality than the patients who had normal serology. And interestingly, of those, the complement appeared to be the most predictive. So having low complement C3 or C4 seemed to have the strongest effect in predicting response, more than the double-stranded DNA, perhaps slightly different to some other therapies in that respect. And I wondered, again, when I looked at this one, about the point we were discussing earlier, are these markers helpful because they tell you something about the immunology, that your molecular target is the correct one for this particular individual, or do they just help identify the people who've got active disease? That if I've got two people with painful joints, one of them's got normals, and we know it's hard to identify disease activity, but one of them's got active serology and one of them's got normal serology. Does the serology help me to tell the one that I should treat and the one that's going to be amenable to any therapy? Or is it something special about this particular mechanism?
Yeah, my bias is towards the second. It's just saying that it's active disease that you can improve, isn't it? It would be lovely if it was about the mechanism, the immunopathology that allowed you to select people. Yeah. But I suspect it's not that, but we'll find out, won't we?
So when we have lots of drugs on the table, we have to wonder whether these markers just tell us use one of them, or whether they tell us use that one.
If we had listened to Peggy Crow's first lecture, basically she showed us that interferon is very much linked to autoantibody production, and particularly the evolution of the autoantibodies. So we were talking about mechanism underlying these improvements in dsDNA or complement. Maybe it doesn't have to always be B cell, but this is kind of interesting because if we listen to her historical thinking about lupus, should have changed the dsDNA antibodies too.
Yeah, that's the other thing. Like, I've seen the same thing as her in my work, which is that when you look at interferon assays against autoantibodies, it's not necessarily double-stranded DNA that's got the strongest association. Right. It's more RNP and Rho.
Right.
Those antibodies that they really correlate with the interferon score, the interferon signature. Or the other thing, best thing of all, is just add up how many autoantibodies you've got. And the more you've got, the higher your interferon score. And that is the target of this drug. Mm-hmm. So, okay, moving on to belimumab. There were 2 abstracts that we've chosen to highlight. And Vibeke, you've taken a closer look at these 2, haven't you?
Yes, I have. So this is the group from the Karolinska, and they were looking at the impact of remission by DORIS, or low disease activity, LLDAS, on health-related quality of life. As I'd already mentioned, we looked at that in the SRI-4 responders versus non-responders at the time of approval of belimumab, and showed that there was statistically significant improvements in health-related quality of life by SF36, but they didn't have any other measures. Here, they're looking at both SF36 and EQ5D, as well as FACIT fatigue, which was in the belimumab trials and was also statistically significant in responders. So the nice thing here is to essentially say that not only were these improvements attained sooner in remission versus LLDAS, but they weren't all that different from each other. But more importantly, these were clinically meaningful improvements they were looking for. In other words, improvements across PCS, MCS, and the domains that met or exceeded MCID, and similarly for FACIT, and similarly for EQ5D. Does this mean then that DORIS is a better outcome measurement than LLDAS? And I think we know that DORIS is more stringent, but we already have seen the benefits of LLDAS. So I think we'd agree, just as we have in RA, if you can get remission, great. But if you can't get remission, low disease activity can often be a very successful endpoint for managing the disease.
Yeah. And that you can see that getting into either of those states is then associated with that improvement in quality of life. So it's meaningful not just for what we as physicians want to measure, but it's meaningful for the patient's experience, isn't it? Which is so vital.
Mm.
So that's something Eric Morand has been working on. You know, he's published that LLDAS is associated with improvements in health-related quality of life. I think he's now working on maybe adding SF36 to the LLDAS definition, which would be nice because it would be a much better composite if it included a patient-reported outcome.
And it makes you wonder, doesn't it, that whether, I mean, I'm used in my clinic, I'm often used to having this conversation with patients saying, well, I've given you this therapy, it's got rid of your joint pain. And they sort of say, well, I'm still really fatigued. And I often say, well, unfortunately, that's much harder to treat. I don't know how to treat that. But then you wonder whether this is saying, actually, if we were a bit more aggressive, if we did try harder with more different targets, whether we could impact on those challenging, stubborn symptoms a bit more than we do with our conventional therapies. I
think we can. It's just that fatigue takes longer usually to show improvements. And that was actually true in this abstract as well.
Yeah. I like the concept of it. You just have to treat longer. It's a bit like in ankylosing spondylitis. To stop new bone formation, you had to treat with biologics for a longer period of time.
Yeah.
And there's some really nice work. You know, it's not part of these abstracts, but looking at how brain structures and the functioning of the brain changes in response to chronic inflammation. And that might explain some of these patient features and brain fog, and they just take time. They don't change immediately. So I think that's really interesting.
And probably adapting to the steroid tapers and things like that. There's several things that change, aren't there? Changing your lifestyle back to that of a normal, a non-lupus person, and these things all take time. Okay, so this is the second one on belimumab that you looked at, isn't it?
Yeah, so this was actually a pooled post hoc analysis of 5 of the phase 3 RCTs. So of course we had 52 and 76, but we also had the Northeast Asia study, NEA, and we had the sub-Q and also the EMBRACE study that was recently published in Black African American and African descent patients from South America and Central America and so on. So essentially what she was showing was that Michelle Petrie was that the severe flares are actually reduced with belimumab treatment across all these trials, about a 39% reduction. And that's highly statistically significant. And interestingly enough, it was best in those patients who had positive dsDNA antibodies and low C3 and C4, not high here. And also, of course, in those who had no damage, meaning that they'd been treated earlier. So that's the argument that belimumab works best in that subpopulation, which we've heard ever since it was first approved.
Yeah. And also that in terms of flares, they'll have the placebo group will have done worse, won't they? In the double-stranded DNA low complement patients. So it's
Yes.
benefit of drug. Okay, moving on to rituximab now. There's one abstract of interest that we've chosen to share with you. Chris, would you like to talk us through this one?
Yeah, and I think this is UK data, so there's a conflict of interest here in that we've contributed, both myself and Ed, to putting patients into this BILAG biologics registry. And this is a registry containing patients with lupus in the UK who go on to biological therapies. There's a whole number of different biological therapies represented, but rituximab is the greatest number. And this was looking at infection risk, and it was particularly looking at infection risk over the first year of treatment, and looking at that compared to patients who are on standard of care in the control group. And essentially, although numerically, if you look at the key results, there was numerically looked like a little bit more infection in total with the rituximab group, that the statistical difference wasn't there. And if you look at serious infection, they're very similar between rituximab and the standard of care therapies. And so I guess that gives reassurance. And I suppose when we're weighing up risk to patients, we tend to tell them patients about the risk of a particular drug and say, well, we're immunosuppressing you, this can cause these problems. But perhaps there are other aspects to this that we might want to discuss now around their disease activity and their steroid use and how that might influence things. And then finally, it's can you pick the people who are going to have infections, and you might expect that those with more comorbidities, those on more steroid, and those who are hypogammaglobulinemic were most likely to get infections. So I thought this was probably reassuring.
I did too, and it's a similar story to what's been seen in the randomized control trials, actually, isn't it, in this real world data? Because in many of the RCTs of rituximab or the other B-cell depleting agents like Iberitamine in lupus, in fact, in those, sometimes the serious infection rate was often quite a lot lower in the patients who were having B-cell depletion than it was on placebo, which I think I find it very interesting, because the conversations you often hear in the clinics, and if I'm talking to maybe my non-rheumatologist colleagues over a complex patient, they're often quite worried when I want to give them biologics, immunosuppressants, that it might increase their risk of infection. And I'm often saying, oh no, it's not giving it that worries me.
Mm. And you look how COVID has taught that across all the patients that we treat. You know, the patients do badly if they have uncontrolled disease activity, not just if we immunosuppress them. And people do badly if they're on too much steroid in terms of infectious risk. And so we've had a really, stark reminder over the last couple of years as well.
Yeah.
So what was interesting in the lupus community hub was there was a lot of discussion about rituximab and the fact that it's not given as regularly as in RA. And so it's actually safer and better tolerated. But I think the other point was there was a big argument about whether it was a good idea to follow Ritux with belimumab or not, given that we have a failed study and a successful study and a lot of differences between the two trials.
Yeah. So it's essentially a lot of the studies you've seen, not just at this conference, but at some of the others, has been essentially a story of like, how hard do you try to hit B cells? Is it just more and more intensive therapy is better and better, more frequent rituximab combining with belimumab, things like this? Or actually, do we want to be a little bit more tailored and just treat when the disease is active and then hold back, let things normalize a bit for a while? So we've got two abstracts on Voxporin that we've selected to discuss in more detail. With all these new drugs getting licensed in lupus now, there's a lot for us to chew over and think about how to use them. So you looked at these, didn't you, Vibeke?
Yeah, so Voxporin is approved in the US, but there's a lot of issue about how much it costs. So this was a pooled analysis of the phase 2 and the phase 3 studies, Aura and Aurora, looking at complete renal response. And the definition, of course, for complete renal response is quite stringent. And that's probably one of the ways that we now have two successful products in lupus nephritis, that we have outcome measures that really function well. So complete renal response, a urine protein creatinine ratio less than or equal to 0.5, and an eGFR that's estimated at greater than or equal to 60 mils per minute per meter square, 1.73, and low glucocorticoids, and of course, no rescue medicines. So they looked at the 23.7 milligram dose, which is the approved dose in both of the trials. And essentially for Voxporin, the complete renal response was 43.7% versus the 23.3% in the control group. And there also was achievement of greater than or equal to 50% reduction and the median time to that. So all of these say that essentially these patients are doing quite well. And because of the trial design, there had to be rapid taper, and they were actually on prednisone less or equal to 2.5 milligrams a day in the majority. And I think that's something that's really been important to us, that show that you can do that with steroids.
One thing I was maybe slightly surprised about when I saw this one is that because Voxporin's a calcineurin inhibitor, which I don't know, I already use tacrolimus in some of my lupus nephritis patients, so so it's a calcineurin inhibitor, and I always thought of those drugs based on the tacrolimus experience being particularly helpful in class 5.
Right.
The patients who have membranous glomerulonephritis, they've got podocyte problems, they've got really heavy proteinuria that's really difficult to treat, which doesn't, and they did include class 5 in this study.
Yes.
Not all the nephritis studies have done, have they? But so it doesn't stand out as being a particular benefit here.
No, as a matter of fact, class 3 did better, which is interesting. But you have to look, because if you look at belimumab, there were really very minimal responses in the class 5 patients.
Yeah.
So we're still seeing a benefit, just not maybe as strong as we might have hoped.
And then maybe it's also, again, just like we were saying before, maybe there's a time issue here, that if your proteinuria starts way, way up here in a very heavily nephrotic patient, then at 52 weeks, you might have improved, but you're not going to get down to the levels you need for these responses.
Yes.
Probably leads into the next abstracts, doesn't it?
Sure. So this is an interim analysis of their extension study. So the extension study is a 2-year extension, and basically 216 patients from the 357 that were in the phase 3 study entered it, and they had 116 on Voxporin and 100 in the control arm. And so they were looking at the mean change in urine protein creatinine ratio at month 30. And essentially it was better for the Voxporin arm in terms of those who'd already made it to month 30 versus the control arm. But the other point is looking at the eGFR over time. What's interesting is it does remain stable. But after Voxporin is started, there's a decrease between like weeks 2 and 4, which is now attributed to the podocyte effects of voclosporin and considered to be, shall we say, expected, although they haven't exactly owned up to that before. But after that little dip, it does increase, but it never gets back to baseline. But then the eGFR remains stable through month 30 in all of the patients who've been on voclosporin. And remember, the control group is still on control therapy. So this is an important set of data for long-term effects of voclosporin, because everyone's asking, what do you do after 2 years of belimumab in lupus nephritis? Well, what do you do after a year of voclosporin? Do you continue it? Remembering that just like the other CNIs, it has effects on hypertension and it has its own effects on renal function, give or take the podocyte mechanism.
You just wonder, don't you, whether this is where we essentially assess drugs in lupus nephritis using surrogate biomarkers of proteinuria and eGFR. But what we really care about is whether we're going to get dialysis, transplants, and deaths, isn't it? And you just wonder whether this is where these biomarkers start showing their weakness, that we don't, how is this going to translate if these people are followed for 10 years?
So we did another analysis. This was with Janssen, but it was the OMRAC working group that we'd done, where we were validating and proving to FDA that SF36, lupus qual, and FACIT fatigue were well validated and very effective measures of PROs in lupus and should be used as supportive outcome measures. Janssen went on further to do patient interviews and find out whether there was a difference between lupus nephritis patients and patients without lupus nephritis in terms of the PROs. And interestingly enough, they had very much the same impacts of disease and described very much the same things. And even in terms of developing symptom questionnaires, they seem to be quite similar. So we are treating the same disease, much as we make these distinctions in terms of outcome measures.
And there's data, aren't there, suggesting that the patients with the musculoskeletal involvement and the pain can have some of the highest impact on quality of life and
exactly.
Yeah. So for the last part of our discussion, we're looking at several of these therapies at earlier stages. So there are some on preclinical studies, and then there are some on early phase clinical studies. Chris, you were going to look at some of the studies that are in the preclinical phases, weren't you?
Yeah, this was fun to do, because it always makes me think back to being in the lab and trying to remember lab knowledge, and to refamiliarize myself with the key animal models as well. So there are 3 that we're going to go through. The first is something I hadn't heard about before. So this molecule Lancel-2, and the particular therapeutic molecule is BT104. So it's an agonist of this particular molecule, Lancel-2. And Lancel-2 sits in cell membranes, and when it's bound to by an agonist, has effects on various things, including cyclic AMP levels in the cells. But the authors suggest that this has an effect on regulatory CD4 cells as well, and other things such as phagocytic effects. And they looked in a few animal models, the classic ones: New Zealand black, New Zealand white mice, F1 mice, MRL mice, and another mouse model I hadn't come across, BM12 adoptive transfer model. And essentially, on a number of different markers, and particularly renal markers that you can see, proteinuria, for example, in the mice, things were improved by this particular molecule. So that's an interesting molecule with a different mechanism of action, showing some promise in animal models. And maybe we'll move on to the next one to think about and talk about them all at the end. This one is something we probably all know a little bit more about in terms of the pathway. So this was looking at a small molecule IRAK4 inhibitor. And it was looking once again in animal models. And of course, the IRAK4 pathway, this is, if you try and imagine the sort of pathways that go through the innate immunity and toll-like receptors leading to interferon production. IRAK4 is in the middle of those pathways. And they looked, once again, they looked in a number of different models and situations. The bit that I thought was interesting about this is that when you look at the poster and you look at the different outcomes at different times, in the studies that they had 2 doses of the drug, and they used cyclophosphamide as an efficacious control, as a control in there, as an active control. And so you can see the molecule in the animal models performing very similarly to cyclophosphamide on various measures of kidney histology and proteinuria, etc. But the one thing that stuck out is that on the cyclophosphamide side, the mice lose weight. So they're getting better generally from the lupus activity, but they seem to be less well and they're losing weight. And actually with this IRAK4 inhibitor, it's pretty equivalent on a lot of those endpoints, but actually they don't lose weight. So that just stuck out in my mind. And this one, Alpen 303, and this is a dual BAFF/APRIL antagonist. And this is using a molecule that we've seen in the past in other treatments, such as Totalizumab, for example, that wasn't so effective. And this is slightly different because what they've done is taken the TACI part of the molecule and then they've engineered it to make it stronger, more effective than the wild type. And then they've looked at the animal models that are mentioned here and some reporter cell lines as well, and can show effects that are, initially encouraging in the same way the other 2 molecules are, around effects on proteinuria and other markers of disease activity within the mice. So I thought those 3 were all interesting and things to watch.
And so what's very interesting about Alpen 303 is that there's Totalizumab, as you said, it had failed and successful trials, but there's Totalizumab, which is from a Chinese company, and it's different. It has a different amino acid sequence, but it behaves quite similarly to Totalizumab. It's actually been approved in China for treatment of lupus, but they're now going further after their relatively small positive trial to show further improvements. It'd be interesting to see because this is different. It's meant to have a better efficacy against BAFF and APRIL.
Yeah, and by this process, domain engineered by direct evolution, which sounded fascinating.
The other one, I mean, when I see these new molecules coming out, the one I always think it's interesting when there's one that's just a very different way of treating from things we do now. And so it was the first one you mentioned. I particularly noticed that this is meant to have some effect on enhancing regulatory T cells.
Yeah.
So everything else we do is always trying to suppress the immune system. But here we're trying to enhance its ability to regulate itself. Yeah. It's just fascinating to think how that would play out in clinical practice, isn't it?
Yeah, and whether that has a different effect on adverse events around infection, that's
yeah.
Yes.
Whether will we care more about maintaining remission and preventing flares or preventing disease progression and new organs rather than just inducing responses.
Yeah, this trial got significantly delayed by COVID because it really just started up right before the pandemic arrived.
Yep.
And one of the ones that are in the earlier phase clinical development that you were going to talk about, because some of those are also have an effect on regulatory T cells, don't they?
Yes, they do. So this is Totalizumab, and it's an anti-CD6 therapy. And it's interesting because this is a phase 1B, and their interim safety analysis is also about a year late because of COVID. And it's an IgG1 monoclonal antibody, binds CD6. It's supposed to block the Alpen interaction, and thus it's supposed to essentially give us inhibition of T effector cells and trafficking. And we've been talking a lot about B cell targeting. Is it really worthwhile to do T cell targeting in lupus? And this should help us know that. It's a relatively small study because it's an interim of a continuing ongoing study. But what's interesting is that they saw really very nice PK, and also that they saw a PD effect, that there was dose-dependent decreases in CD cell surface expression of CD6. and it was well tolerated. There were some injection site reactions, but essentially they didn't see any effect of anti-drug antibodies on their PK. And then we can move on to the next one. And this is efavilucan alpha. So it's one of 3 IL-2 therapies designed to increase Tregs in lupus patients with the idea that we will get better control of disease. This is an IL-2 mutant from Amgen, actually. And this is interim results from their phase 1b multiple ascending dose study. So they're really only looking at patients who received every other week therapy, although they have a cohort that's getting weekly therapy as well. It was well tolerated. The PK again was linear and dose proportional. This is a sub-Q therapy. The FOXP3 Treg expansion was observed about 8 days after each dose and was generally sustained. And at the highest dose that they've measured so far, they showed a 53.8-fold increase, which is quite impressive in the number of Tregs. And they're arguing that these are different Tregs because more of them were naive and more of them also were essentially from what we would call a thymic immigrant population, a CD31 positive population. So this is very promising. As I said, there are 2 other programs working on IL-2 for increasing Tregs. This is Iberitamine. So we've heard about Iberitamine. We've heard about this phase 2. Part A was done in lupus patients and part B was done in cutaneous lupus or discoid lupus patients. And part 2 had multiple, or part B had multiple doses, but part A was simply to look at lupus patients without necessarily cutaneous manifestations other than rash and et cetera. And here the dose of Iberitamine was the 450 milligram dose, which was the highest dose. And essentially they looked at patients who then were also on placebo, and after the 24 weeks, they were then randomized to the 2 upper doses. And I'm sorry, I said 450. I was talking about 0.45, 0.3, and 0.15 milligrams. So it's interesting because what we saw is that the SRI-4 responses were better in the Iberitamine groups. There really wasn't a dose response. It was a little confusing. And then when they looked at the 52-week data, it was again a little different between the different doses. But to some extent, you would argue that the lower dose did better. What we do know, though, is that those patients who had the interferon high signature or the Aiolos high signature, one of the ligands, cereblon ligands that this inhibits, did better than the others. Well tolerated. We still have a lot to learn about this product. And I have no idea how they're going to select doses to go forward. And finally, this is BIIB059, which has been studied in cutaneous lupus, but also in a part A, which was patients with generalized lupus. So this is going back, looking at the patients with generalized lupus after they've had the treatment. And essentially what we're looking at is joint manifestations. So apparently SRI and all these other things, skin and joint, that's okay. But now we have to look at joints. 50% improvement in both tender and joint counts, 50% improvement in tender, but not swollen joint counts. It just gets to be more and more, I don't know whether it's useful, but the point was that it's convincing that it certainly does improve joints. And then we go back to, well, what we should be measuring in these lupus trials is skin and joints. Well, of course, that's what everybody with lupus with active disease has, the skin and joints, but we're also treating their internal organ manifestations or the other manifestations that are making them feel bad, as well as their skin and joints. So I'm not entirely sure that looking at joints or looking at skin in patients with DLE or CLE is the most convincing way of showing efficacy, but I'm willing to see the data. And one of the points in this group was that there was resolution of arthritis by the SLEDAI-2K in 48% who received BIIB versus the control group. And they also looked at bilag evaluation of joints, which is more specific than the SLEDAI.
It's very difficult to tell what all those different arthritis outcome measures really mean, isn't it? Because the SLEDAI resolution, it has a threshold, doesn't it? On the SLEDAI,
Yes.
you can go from 30 joints to 5 joints, and you don't have resolution.
No,
yeah.
unless you use the S2K-RI50.
Yeah.
If you get 50% improvement. So, both the bilag and the SLEDAI have problems with their use.
Yeah, and if we want to get into the kind of questions we've been talking about today, sort of, does it work on this manifestation or that manifestation with that biomarker? We just don't have the tools at the moment to really interpret those trials to get that information that we need, have we?
It's interesting too, because SRI4 responders are not necessarily BICLA responders and vice versa. And I've monitored a lot of trials where we're looking at both bilag and SLEDAI. And it's very hard to make sure that the findings are consistently reported, because the findings are not consistent according to those two disease activity measures.
Yeah, and it's very hard if you see when you're adjudicating these trials, when you see the data that the investigators have recalled and you're asked, is this right? And unless you fly out to the site yourself, it's very difficult to tell, isn't it?
Well, what we do then is we flag them for a specific visit to look at the data, because they don't agree.
Yeah.
I mean, they don't agree in ways that we know must mean there's some question about how they were completed.
So just going back to the first one you talked about, was it the first or the second, actually, the one with the low dose IL-2? That, like you mentioned, that's a strategy that's got quite a history in rheumatology now, hasn't it?
Yes, it does. Yes,
there's been some academic studies in France and Germany and China, haven't there, before these pharma trials, and it just hasn't quite, it sounds exciting, but just hasn't quite made it into a big positive trial.
No. Well, the Chinese study was positive, but I think we had a lot of questions about the data. The German study was small and positive. I mean, we could go back to when we were giving IL-2 for HIV infections.
Yeah.
And the problem there was that it wasn't very well tolerated. It made people pretty darn sick. So what's happening here is they're trying to figure out ways to give very, very low doses of IL-2 that are better tolerated, and thus the mutein and so on.
So I think that's the end of the abstracts that we've selected. So I guess it's just to say thank you to you both for joining us and for your overview and your insight. And thank you to the audience for joining us to review these abstracts. It's been a fantastic meeting, and it's been high quality data. And I think, as we said at the start, it did work well as a virtual meeting, actually. And the discussions we had with our colleagues there were also very fruitful. It's great to see all these different therapies in development, all of them targeting different pathways, and it just shows what an interesting few years it's going to be. So for the audience members, as with most of the things on the Lupus forum, you can download the slides that are shared in this review, and you can use those to keep yourself up to date or in your own teaching to your colleagues. And if you go through the website, you'll find a lot of other slides there on the existing therapies, some of the older data, and the newest publications that come out on a monthly basis. So you just have to go to www.lupus-forum.com. Thanks for joining us. I hope you've enjoyed this review, and we'll see you for the same next year.